A little bit. We are going to start in spite of the technology. So if it wants to play part, it will find us on the way. So we haven't had our weekly media briefings in a while. I think the last time we had one was just before the State of the Province address. But we are here today, so the Premier is here and the MEC for Health and the members of the Advisory Committee. The Premier will make short remarks and explain the areas that we'll touch in the briefing today, which will basically be about our health response and the vaccination program. And then we will get different members of the panel to present on the issues. And at the end, the Premier will come back and give his closing remarks. So without any further waste of time, I would like to call upon the Premier to speak to you.
Thank you very much, Thabo. Good afternoon, ladies and gentlemen from the media and the people at home. The Gauteng Provincial Coronavirus Command Council has been meeting every week. We meet every Tuesday. We bring in those meetings the mayors and the city managers of our district and metros. Those meetings are preceded by extensive assessments by the teams of technical officials, the work streams that look at all the various issues. So even though we haven't done a media briefing since our last one on the 12th of February, because we're preparing for the State of the Province address. But every week on Tuesdays, the Command Council does meet. We met again this week on Tuesday and assessed the trajectory of the pandemic in our province, assessed what is happening with the implementation study, phase 3B, which is led by the MRC, the Medical Research Council, currently focusing on the J&J vaccination of our healthcare workers. We reviewed that, but we have also been doing extensive work in preparation to what is coming. There are important things that are worrying us. We are moving towards Easter. The Easter weekend is a weekend where large number of people move out of our province, so the level and extent of mobility, increased mobility, is always an important risk factor with regard to the spread or the potential spread of COVID-19. The infection rate, its relationship with increased interaction amongst people and mobility. So we are getting to the Easter weekend. So the Command Council has been looking at what that might mean, but we are also moving to winter. So there's two at the backdrop of this is the Easter weekend, and we are moving to winter. And again, during winter, we ordinarily worry about the flu season, and our teams, our health teams, have also been reviewing what they normally do during winter. They do immunization, flu immunization during winter. They looked at what we did in 2020. There are also other immunization programs, but we also extensively looked at the real vaccine rollout, the extent to which our province is ready, and the extent to which when we get the larger number of doses, how we are going to go about the vaccination program. So you will get a briefing today on 3 issues. The first one is from the Advisory Committee on COVID-19. So the Gauteng Advisory Committee on COVID-19, that is the group of scientists. Again, I want to emphasize, in that team you have health scientists, you have social scientists, you have data scientists, and you have a very diverse team of scientists. It includes clinicians, those who are in the front line, who are dealing with COVID in the wards. We've got several clinicians there who are in that advisory committee. They give us the data and the trends, their observations about what is happening in the wards. They are assisted by the other teams of scientists. So the Provincial Command Council in Gauteng has benefited greatly from their tracking. They work with other research teams that track, do risk profiling in Gauteng, what is the nature of risk, what are the communities in Gauteng like. So the first input today is going to be given by Dr. Mary Kaunga, who's the chair of our Provincial Advisory Committee on COVID-19. She will present with Professor Bruce Melado. They often do that together. Bruce often looks at the hotspots, what's happening in the hotspots, the mapping of the hotspots, the implications of these trends for the future. Mary often just looks at the behavior of the pandemic and factor what is coming from the feedback from the hospitals, those who are on the front line there, and the feedback from the health system. What is it that we are observing from that? So we always anchor our response on the science. So the first presentation is on the science and the specifics of the pandemic in Gauteng. This team has guided us throughout the pandemic from March 2020, although we appointed them later, but some of them had already been working with us in different ways. They've guided us through the first wave, the peak of the first wave, and then through the second wave. And it is through them, I pay tribute to them, it is through them that we've been able to respond. So they are already, you would see, that's what that presentation is about. They are already giving us some indication that certain trends are emerging about the possibility of the third wave and what is it that we can do. And it is our responsibility to communicate truthfully to the people of Gauteng, to share this information with the citizens of our province in advance, to send the warning signs as they are coming, but to also avoid panic, to also send advice. What is it we should be doing? So today we will focus on this, and then we will focus on the vaccination program. The inputs of today will be on that. Dr. Senabe is going to present a detailed approach to vaccination in Gauteng. Where do we want to start? As soon as we get the sufficient number of doses outside the current implementation study, where are we going to start? How have we organized ourselves? Which sections of the populations will be a priority? how are we going to overcome all the problems? And Ms. Mupe will give us feedback on the current implementation study, and we will take questions thereafter. So on this note, I would like to call on Dr. Mary Kaunga to take us through. Immediately after that, she will call Bruce. They know how they normally present this to us. They do this work on behalf of the Advisory Committee on COVID-19. Over to you, Dr. Mary Kaunga.
Good afternoon. Thank you very much, Premier, MEC, colleagues, members of the media and public in Gauteng. Good afternoon, everybody. So as the Premier mentioned, myself and Prof. Melado will start off by just giving an overview of the status of the COVID-19 pandemic, particularly looking at the second wave. And then we'll also be looking ahead at the anticipated third wave, and we'll be presenting some of the work that's being done for early detection of the third wave. So I'll just start now and hope this is working. Okay, thank you. So just to begin with, I want to start with where we are now. And so what we've been doing is we've been looking at the metrics that have been developed by a group called the South African COVID-19 Modeling Consortium, which I'm sure you're all familiar with. And they've developed some metrics that define different stages of the COVID-19 pandemic. They define the peak, they define when does a wave start, when do you decide that the wave has ended. And so what this table is showing really is that the different stages of the first and second wave in the Gauteng pandemic. And as you can see, the peak of the first wave for Gauteng was 12th of July, based on the metrics that they developed, and the peak of the second wave was the 10th of January. And the numbers of the peak were very similar for the first and second wave. But the section that I've highlighted, which I want to draw your attention to, is that the second wave officially, based on the metrics, ended on the 7th of February. And so that means we've been about 6 weeks now into the post-wave stage of the pandemic, and that's where we are at the moment. Next slide. So now this slide is really just looking at both the first and second wave and really just emphasizing what I mentioned just now. So at the bottom of the slide, you can see there are different sections highlighting the different phases of the pandemic: the first wave, the first post-wave period, and the second wave. And you can see that the first wave was about 80 days, the second wave was 114 days, and the wave that we've just finished now was about 50 days. So I mean, the second wave we know was very precipitate. The numbers increased really rapidly, peaked for a very short time before we started seeing a reduction and a rapid deceleration of the numbers. So we didn't stay very long at the peak before the numbers started to go down. Just a couple of things to just highlight. We've been looking at the comparison between the first and second wave. In terms of the numbers, I mean, if you look at a daily rate comparing the two, they're very similar, except that maybe because the second wave was a bit shorter, the average number of cases per day was slightly about 10% higher. And if you look at the number of deaths per day, average daily deaths, they were higher in the second wave compared to the first wave. So this is kind of giving some indication in a way that perhaps the second wave was slightly more severe than the first. And this sort of adds to the data that we've received from the NICD that indicates even in terms of hospitalizations and hospitalizations mortality, the second wave was more severe than the first one. And then just finally on this slide, I mean, I think we just did a little bit of a comparison also comparing Gauteng to the rest of the other provinces in the country. And I think compared to the other provinces in the country, particularly the coastal provinces that were hard hit by the second wave, Gauteng seemingly sort of, we got off a little bit lightly compared to the other provinces. The second wave was not worse than the first. And I mean, one of the reasons that we think accounts for this is because by the time the level 3 lockdown, alert level 3 was implemented, it was a very timely implementation of public health and social measures. So the rate at which the second wave was going, our conclusion is that if that level 3 had not been imposed, perhaps we would have seen an even worse second wave. So that's some good news that we're seeing there. So, and there are obviously, since the lockdown level 3 has been implemented and we're now in lockdown level 1, there's been adherence to public health and social measures, mask wearing, and masking was now a mandate. And so that all contributed to the reduction of the second wave. So we're now in the post-wave phase after the second wave. So the last thing I want to say on this slide is, even though we're in the post-wave phase, the current post-wave phase is still, the numbers we're seeing are still higher than the ones we were seeing in the first post-wave stage. So the numbers of cases, the numbers of deaths, particularly the cases, have not gone down to the level that we were before the second wave started. And one of the other things we wanted to note, which I'm going to talk about perhaps in the next slide. Next slide, please. The other thing I want us to note is that when you look at this current post-wave phase, for the last 8 weeks, we've been tracking weekly number of cases of COVID-19 in the province. And for the last 8 weeks, we've been seeing a downward trend. But then the epidemic week ending the 13th of March, there was an upward trend for the first time in the last 10 weeks. And that is something that's a little bit concerning and is something we need to monitor a bit more closely. And at this point, I'd like to ask Prof. Malado to come and take over to elaborate a little bit more. Oh no, I have another slide, apologies, before Prof. Malado comes on. So the last slide I want to just present before I call Bruce is that, as you know, in the last press briefings, we've been presenting graphs on the number of cases, number of deaths, number of hospitalizations, and the number of cases, tests that are positive, so the percentage test positive. So if we summarize all that information and put it into one table, so what this table I'm showing here presents what the WHO has referred to as different levels of community transmission. And the levels of community transmission are categorized into low, medium, high, and very high risk. And so if you can look at this table, and the 4 indicators that I'm talking about are in the first column. In terms of hospitalization rates, we're now sitting at like 3.1 hospitalizations per 100,000 people. This is based on an average of the last 2 weeks. And so that's an indication of low level of community transmission. So in other words, the risk of infection to the community is low if you look only at hospitalizations. But if you look at deaths and percentage test positive, and there's a very strong correlation between those two, and the MRC has also, in their most recent report, indicated that there's a very close correlation also between percentage test positive and excess deaths. If you look at those 2 indicators, which are considered very sort of good indicators of a pandemic, we are still at what's referred to as moderate risk. So in other words, the risk of infection in the community is at a moderate level. So this is why one of the reasons when you hear us in this presentation, when we present and say we're still concerned about the possibility of a third wave, and we don't feel we're ready to breathe a sigh of relief, is because we're still seeing these indicators indicating that we're not yet out of the woods. Can we go back to the previous slide, and then I'll hand over to Prof. Malado for now, and then I'll come back. Thanks.
Thanks, Premier, thanks, MEC, and thanks, Dr. Kawonga. So as Dr. Kawonga already indicated, we have reached a very particular situation where the numbers of cases has stopped dropping. This basically means that we have reached a new situation of equilibrium between the number of cases created by local transmission and the local reproductive numbers. Now, unfortunately, the fact that we have dropped and reached that equilibrium and stopped dropping the numbers means essentially that we are highly exposed to a third wave. This equilibrium is unstable. Any triggers such as super spreader events or similar situations where we can have a spark in the number of cases will break that equilibrium and lead to a third wave. As a result of that, we are highly vulnerable to super spreader events. This is a time where we have to be extremely careful about the fact that things like super spreader events will now become a trigger for the third wave. So we have to be extremely alert. Can we go next one, please? In order to assess where we are, we have to look at a more, so to say, localized and microscopic picture. The first thing, as already indicated by the Premier, is to look at the situation of the hotspots in the province. Hotspots are small mini pandemics. They are localized geographically. We're able to identify them and go down even to the street level to understand where they are. Now, the good news so far, and this is a graph of the situation with hotspots in Tshwane. The color code is an indication of the risk index. This risk index basically tells you how dangerous the hotspots are. The fact that they all have light colors basically means that the risk is quite low. So currently, the hotspots we have in the province are growing very slowly and don't pose a threat by themselves. This basically means that we have not yet reached, or we're not yet in a situation where we have a third wave. Let's go to the next slide, please. This is the same situation for Johannesburg and Ekurhuleni. We have quite a number. It's decreasing, of course, but they are clearly not dangerous hotspots. So this doesn't mean that we're out of the woods. It basically means that we are not yet in a third wave situation. When the third wave comes, should it come, you will see gradually the color of those hotspots will become more red and red, indicating that they're growing faster and they're becoming more and more dangerous. We have to monitor this very, very carefully because the pandemic doesn't evolve homogeneously in the province, but it does really in certain areas, or other areas are not as active. It's very important to monitor the creation of hotspots. Let's go next, please. Now let's talk about the risk index. The risk index, as already indicated by Dr. Kawonga, help us understand where we are in the pandemic. You have a graph or the time series of the risk index before the second wave, during the second wave, and past the second wave, indicating what sort of values do we use to determine that we are in the middle of a wave or we're going towards a wave. And this also serves as an early detection algorithm for the third wave. When we see that the numbers go above 7.5 and 10, we have a strong indications that a third wave is upon us. Now, right now, the average situation in the province is that the risk is below medium. That is good news, but the concern is that the risk index is not distributed homogeneously across the geography. We have districts that have not yet gone below that risk, and that is a serious source of concern, and in fact, an additional vulnerability in regard to super spreader events and the third wave. Can we go next, please? So to illustrate that, we can go deeper into at the level of districts where we have Johannesburg, Ekurhuleni, Citibank, Tshwane, and the West Rand. It's nice to see, for instance, that the risk index is pretty low for Tshwane, but we can see a situation where Citibank hasn't yet gone below, and that's a very big source of concern because people move around and we see areas where local transmission is still quite active, and we need to monitor those very carefully. So we have to go deeper to the next level from the point of view of the administrative division of the province. Can we go next? This is an example of a sub-district. You see here in the graph the cumulative number of cases where you have in Mfuleni compared to other sub-districts which have a similar number of cumulative cases. We have to compare apples and apples. We see clearly this much faster growth in the number of cases in that sub-district of Citibank compared to others. So this is something that we have to monitor very closely, and as I said earlier, it basically adds to the vulnerability of the province against a third wave. Let's go next. We also look deeper into the situation in Johannesburg. Johannesburg D and G still remain with a relatively high risk, and that is a source of concern because people move. And even though you have areas where the risk is much lower, because people move, they can actually, in conjunction with super spread events, basically generate a third wave. That's the upper graph, that's Johannesburg. The lower graph is Tshwane, where overall the situation there is of low risk, which is good news. Yet, we have other sub-districts in the province that don't display such a positive picture. Can we go next? And for instance, another area of concern is Ekurhuleni South and North. You can see that in the graph. The blue and the red curves still remain above mid-risk, which is fairly high, taking into account that, as already Dr. Kawonga indicated, the peak happened about 2 months ago. So by this time, the number should have been basically much lower and be at the level where, for instance, the light blue is right now. So I think that's it. I'll give the floor back to Dr. Kawonga. Thank you.
Thanks very much, Prof. Malado. Okay, so just maybe 3 more slides to finish off this presentation. So what we've presented so far are some epidemiological indicators. We've presented some risk indices. So when you look at both those situations, they're telling us that we're still at low to medium risk of infection transmission in this province. And as Prof. Malado mentioned, that the risk is not evenly distributed across all the sub-districts, and so that's one of the reasons why we need to be cautious, because some are at a high risk and some are at a low risk. So there are other reasons, apart from the epidemiological indicators, that are cause for concern at the moment. And so I'm presenting this graphic, which was put together based on some ideas from some infectious disease academics in the US who are defining the potential third wave or subsequent waves as a hurricane. I don't want to cause alarm, but really, so they're saying there are a number of factors in combination. When they act together in combination, they're giving us concern that third waves are potentially going to happen in different regions of the world. And so the main factors that have been put forward are, if you look at it, the virus mutations. We know about the variant, the new variant 501YV2 in South Africa, and there are others that are in other countries, the one in Brazil, etc. And so the possibility of reinfections with variants have been raised, though at the moment there's very little data to support that reinfections are common. They're rare, but then recent work coming out of the UK is actually showing that they're rare, but the people most likely to get reinfected are elderly people. So just giving us indication that elderly people are probably the most at risk. And apart from variants and reinfection possibility, the 2 areas that I'm going to talk about just now are the fact that whenever we relax public health and social measures, moving from a more stringent lockdown level to a less stringent lockdown level, often we see people changing their behavior. And then the other factor is the vaccination delays that are not just in South Africa, but globally. Most countries haven't reached the vaccination levels that they had anticipated when they started out. So I think if you combine those 2, in terms of relaxed, if we can go to the next slide, please. Next. Yes, so on the left, if you think about relaxed preventions, I think moving down to lockdown level 1, I mean, it's been several weeks. We haven't seen any alarming increases. I mean, we've seen, as I mentioned, in the last epidemic week, we saw an increase in number of cases for the first time after 8 weeks of monitoring, and we're going to monitor that very closely. But then, as we've said, as we noted earlier, often when we relax measures and they become less stringent, often what follows is people's behavior starts to change. So gatherings come back, people feel that they're now liberated. And so that's one of the issues that we're most concerned about. The Premier spoke about these, and so did Bruce, as super spreading events. And I think the fact that we've now moved to lockdown level 1, and we're now just soon before this long weekend that's coming up, 2 weeks later we're going to have the Easter weekend, family gatherings, religious and social gatherings are likely to happen. And so that's one of the reasons that there's caution about relaxed interventions. Measures. So the other thing that's worrying us, apart from the super spreading events, are gatherings in households. I know it sometimes seems safe to gather with friends and family, but one of the things that's coming out of the literature, the data globally, is often when we mix households, people from different households in small gatherings, they're also a risk. And so I think we just need to ask people to be cautious that when we are gathering in small gatherings, convening in small gatherings, they are also a risk, and we still need to uphold the measures such as wearing masks and social distancing and washing hands and so on. And the last thing that, before that, the last thing that we're also concerned about is obviously when we relax measures and we start seeing an increase in cases, is that we start seeing a demand on hospitalizations. And so that's where we're also concerned about the fact that our hospital sector might get stretched because of the potential increase in cases. So if you look at the right-hand side, there's also threats related to delayed vaccination, is that by the time we get to the long weekend for Easter, by the time we start seeing cooler weather when people start gathering indoors, we would not have vaccinated enough people to be able to protect the community and prevent a potential third wave. So the vaccination has started, which is great news, and it's giving individual protection to the health workers, which is excellent. But what we're saying is we have not vaccinated enough people to get to a point where we're protecting the community and preventing a potential third wave. And so we really do need to continue with our public health and social measures. Can we move to the next slide, please? Thank you. So just what is this? What are we saying in conclusion? So in conclusion, the second wave is over. We're now in the post-wave stage. The cases are not as high as they were 8-10 weeks ago, but they're still not low enough for where we want them to be. So community transmission is still ongoing, medium to low risk of transmission in our community. The vaccination has started, which is giving us hope. But as I mentioned just now, we've not vaccinated enough people to have an impact on the third wave. And so our key message today is that please let's continue adhering to wearing masks, sanitizing, washing hands, avoiding crowds, avoiding confined spaces. Particularly in the next few weeks between now and the Easter weekend, and even during and after the Easter weekend, let's avoid travel unless it's really essential. Avoid gatherings, because big gatherings can become super spreading events very quickly. But also let's just be cautious when we gather in our families, at households, in small groups, when we're mixing people coming from different households, because different households will have different levels of risk. As we said, Gauteng is a non-homogeneous population. Different areas have different levels of risk and so on. So those are the cautionary precautions we're putting forward as the final word on this matter. Thank you very much. Thanks, Premier.
Thank you.
All right. Now we come to the next presentation, which will be done by Mrs. Mupe. She is the acting COO in the Department of Health, and she is also leading our vaccination program. So, Mrs. Mupe, the stage is yours. She will explain to us exactly where we are and what is the way forward.
Good afternoon, Premier. Good afternoon to members of the media, our MEC and colleagues in the House. I'm going to give an update of the vaccine rollout in Gauteng. I think it's slide number 15 or 16. There you go, just up a bit. Yes, thank you. Today I'm going to be giving an update since our last briefing. In our last briefing, I presented in detail the Gauteng City Region vaccination plan. So today I'm going to be giving an update of what has happened since the last media briefing. So as Gauteng is a province, we started implementing the Sisonke Early Access Study on the 17th of February. And this was implemented in two hospitals, that is Chris Hani Baragwanath and Steve Biko academic hospitals. And 4 sites were added to the 2 to make 6 sites. 2 of these were in the public sector, that is Dr. George Mukhari Academic Hospital and Charlotte Macheke, Johannesburg Academic Hospitals. And then we had 2 from the private sector, which was Netcare, Melpak, and the Lenmed Ahmed Kathrada private hospitals. And the Mediclinic Medforum was added in the last week as one of the sites that are going to be vaccinating. So as a province, as the Premier often says, we don't procure vaccines, we wait for the National Department of Health to procure, and then we just receive and administer the vaccines in the selected sites. It's safe to say that the vaccination program currently is implemented in 6 sites. 3 of these sites are in the public sector and the remaining 3 are in the private sector. And it is mainly for targeted healthcare workers. It's not all healthcare workers. It's targeted healthcare workers. And I think this target population, I explained it in the last media briefing, what we mean by a prioritized, categorized, targeted healthcare workers. I explained that in details. Next slide, please. So in the last media briefing, I did indicate that the vaccination program is going to be done in 3 phases. We are currently implementing phase 1 of the study, and I'm not going to talk about the other 2 phases because we're not yet there. We are still implementing phase 1. As Gauteng, out of the 1.2 million people targeted in the first phase, Gauteng has been allocated. We have 215,000 healthcare workers that we must vaccinate. As at yesterday's report, we had vaccinated 43,915 healthcare workers. Next slide. So these 6 sites that have been allocated, they don't only focus on healthcare workers in those particular hospitals. There are cluster hospitals that are linked to these main big hospitals. And vaccinations do take place from healthcare workers that come from the cluster hospitals. They are part of the 6 hospitals. So people in the main think that when vaccination happens at Charlotte Macheke only vaccinates healthcare workers in Charlotte. No. Charlotte Macheke has got about 11 cluster hospitals that send their healthcare workers, those that are targeted for vaccinations. And George Mukhari, as you can see, it has got 5. They identified there, and Chris Hani Baragwanath has that long list, and Medforum you can see, and Ahmed Kathrada is the one that has got the fewest. It's only 2, that is Dr. S.K. Matseke Memorial Hospital and the Lenmed Daxina hospitals. Next slide. So what has happened is that when we got our first tranche, we were given 16,800 vaccines as Gauteng, and we were expected to vaccinate or use all the vaccines in 14 days. But because the demand has been so high from our healthcare workers, we completed those doses in 10 days. And then we're given our second batch. On the 1st of March, we're given 18,040 vaccines. And we were able to complete all the 18,040 vaccines in 11 days, as opposed to 14 days. We currently are vaccinating from the 3rd batch that we received. We received 10,200, and I think by the end of today, all those doses will be completed. We are expecting the second tranche of the 3rd batch on the 22nd of March, but we should be able to complete that. The uptake is very high. Healthcare workers are very motivated because this is something that gives them hope, and they are coming for vaccination, and we are vaccinating them. Next slide. So as I indicated in the 2 slides before this one, as at yesterday, as a country, South Africa, we had vaccinated 175,428 healthcare workers, and 43,915 of those were in Gauteng. As you can see, the bar graphs, they're in red. Gauteng seem to have vaccinated more than any other healthcare worker that is vaccinated is in other provinces. We are having the highest number, and we really are motivated. If we had adequate vaccinations, we would have exceeded this number by far, but we can only wait and vaccinate based on the numbers of vaccines that we receive. Next slide, please. So if you look at how the vaccinations are done per district, you take that 43,915 and you disaggregate it by district, and it gives you the number. So we know in each district how many healthcare workers came for vaccination. So in the private sector, there are 12,223 vaccinations that have been done, and in the public sector, it's 31,000. Then it gives you the total of 43,915. Next slide. So we also can give you data on the how many vaccinations are done per hospital or hospital group. As you can see, Steve Biko vaccinated the most, followed by Chrisani Baragwanath and Charlotte Majeke, and then we had Netcare, the group as Netcare, that came after the third hospital from the public sector. And you can see how the vaccination is happening per hospital. Next slide. So this is the figures that we were allocated for the 15th of March. As I said, it's 10,200 of those. And as at yesterday, we had done 8,980 of those doses, which translates to 88%. When we close the day today, because we normally receive our reports at 6:30 every evening, when all the sites have been rounded up to get the figures of how many people are vaccinated, I'm sure we are going to be at 100%. We are at 88%. And as you can see, Netcare is leading at 99%, followed by Dr. Mukari and Charlotte Majeke. But as you can say, the Milpark is leading at 99%, but also take into consideration the number of vaccines they have received. Most of the vaccines were allocated to Charlotte Majeke. Next slide. The side effects that we have experienced across all the vaccinating sites are 97 as at yesterday. In the main, 96 actually of those side effects were just minor things where a person would complain about the arm being sore where they were vaccinated, or a little bit of swelling, a mild headache, and some people say they are feeling dizzy. But because we do have an area for observing them after vaccination, they stay there after 15 minutes, they are okay, and they go home. We did only have one adverse event. It's still under investigation. We still have to hear what happened. And as indicated in the last briefing, the Medical Research Council is the one that deals with the adverse events. We report to them, and they follow up the patients and do their full workup on the patients. Next slide. So in conclusion, Premier, the vaccination progress under the circumstances is progressing relatively well. The uptake is good, as I indicated. We don't have major changes to the plan. Remember when I was here in the last media briefing, I presented the big plan for Gauteng. That plan is still in place. We had to readjust it to suit the Sisonke rollout program for phase 1. As soon as we get into the other phases, our plan is going to kick in. As I said, we're still on phase 1, and we await the delivery of the next batches from the National Department of Health, and preparations for rollout of phase 2, which is the biggest phase, as Premier has said. We would be ready to do that because we do have an original plan. I think this is the last slide. Thank you so much, Premier.
All right, thank you very much, Mrs. Mope. So as we explained earlier, the vaccination program is in two parts. So the first one was presented by Mrs. Nomsa Mupe, and then we now have Dr. Sinabe, who is going to explain the approach to our vaccination, how we hope to deal with the bigger population as we move to phase 2. Dr. Sinabe.
Thank you, DDG, and greetings to the Premier, the MEC, members of the media, and colleagues. I'm going to present on the identification and prioritization of our target populations for COVID-19. In this work, we are going to be guided by certain sets of instruments adopted or borrowed from internationally at the WHO, and some of the work that has been done in Gauteng. From the WHO side, it is the WHO SAGE Values Framework and the WHO SAGE Prioritization Roadmap. By SAGE, we mean a special advisory group on immunization that have a group of experts that have guided on both the framework and the prioritization. In terms of the values and principles that we will be following, one is that we are going to be using statistics that is led by the Stats SA as the competent authority within government to guide on any statistic that we use to inform policy. And we are also going to be guided by a second principle of striving for equity in everything that we do. Next slide. So with regard to the WHO SAGE Prioritization Roadmap, this is the slide that has been applied and it has been presented before. So what the SAGE Prioritization Roadmap is helping us with is to have these phases 1, 2, and 3, as has been said before. Next slide. So with regard to the values framework, we are going to be guided by the following 6 principles. The first one is that of human well-being. The objective here is to reduce deaths and disease. And we are going to be guided by age, comorbidity, and socioeconomic vulnerability as the 3 factors that contribute to the reduction of deaths and reduction of disease. And there has been a lot that has been said around this issue, but safe on the socioeconomic vulnerabilities is that we have started with health workers, we have now going to essential workers, and then we are going to be looking at those living in dense urban neighborhoods and also those living in multi-generational households as some of the social drivers of the epidemic. Next slide. So still on the human well-being, we are also going to be looking at the things that will reduce societal and economic disruption. Making sure that, for example, we have school-age children to minimize disruption of education and socio-emotional development. And those workers that are working in terms of emergency outbreak response, and those workers in non-essential but economically critical sectors. So all of this will be part of phase 2. And then the other objective in relation to human well-being is to protect the continuing functioning of the essential services like health services. And we have started with health workers. We are now we are going to phase 2, where we will have other essential workers, and it will be according to their risk of getting infected to COVID. It will also include government leaders, administrative and technical personnel that are critical for the functioning of the state, and also other personnel that are going to ensure that we are having other health services. Next slide. So the other principle is that of equal respect This is where we are assuming that all human beings are moral equals, and therefore they are supposed to have equal respect for all of people, and ensure that they have equal consideration for vaccination and meaningful opportunity to be vaccinated, all of them, with no one being left unvaccinated. Next slide. The next slide is about global equity. Here is more at an international level, just to make sure that low and middle income countries also have access to vaccination. As a country, we know we are in the process of selling some of the vaccines to other countries in the African region, and also to make sure that those citizens of countries in the middle income countries and developing countries who are in our province, Gauteng in particular, that they are also not left out of the vaccination program. Next slide. At a national or a provincial equity, here it is just to make sure that as we are going to be vaccinating, we will prioritize in an equitable way people living in poverty and essentially extreme poverty. And this would include homeless people, persons who are disadvantaged, people who are in low income environment like migrants and other people who are mine workers, construction and so on. And then also those who are hard to reach populations in confined groups. Next slide. Still on the national and provincial equity, we will ensure that we develop an immunizational delivery systems and infrastructure that is required for COVID vaccines to access in terms of those priority populations, to make proactive action to ensure equal access to everybody who qualifies, so that we do not have unjust disparities that are of the past perpetuated, but that we are also going to ensure that those who are experiencing serious COVID illnesses, persons above 60, persons with comorbidities, and persons living in conditions where they cannot implement the non-pharmaceutical interventions of social distancing, those who do not have flush toilets and regular access to water so that they can do their hand washing, those will be equitably also considered. Next slide. This is the principle of reciprocity. It is basically prioritizing people according to the risk of getting infections. We do know that not all people are having the risk of infections the same way, and we have started by applying this principle by starting with health workers. We know that health workers are more at risk than others. Now we are going to the essential workers, law enforcement people, people who are in critical manufacturing, finance, retail, etc. We will also do that according to their risks. Next slide. Legitimacy here is really a process, a principle we will use in our planning, so that whatever we do, it is scientific, based on evidence, expertise, on significant engagement with other people and communities, is transparent, accountable, unbiased in all that we do, so that we can ensure that there is trust in the whole campaign, and that we will not have self-dealing activities. Next slide. So in relation to the work that was done in South Africa, there is this vulnerability index, which was really led by the Gauteng City Region Observatory, the GCRO. They have identified a whole lot of variables or indices that are indicating socio-economic vulnerability, like household crowding, not having enough sanitation, not having access to clean water, reliance on public transport, reliance on public health facilities, and so on and so on. They have put all of this together into an index that really looks at the most important things that make people to be vulnerable, so the ability of social distancing and preventive hygiene like washing hands, etc. And also the social and health vulnerability factors. They have then mapped them and then looked at, in particular, those that are living in populations that are dense and where there is also overcrowding. Next slide. They have then put these indices according to 4 categories so that we know how to then identify these populations. The first one is for those people who have higher than average risk. In other words, it is easier for them they are at a higher risk of getting COVID and a high population density, and they live in situations where there are many. And those are in the red right upper quadrant with those red dots. And then moving anti-clockwise, we then look at the risks that are reducing. Number 2 is higher than average risk of getting COVID, but you are living in an average population density that is also reduced compared to the first one. The third one, lower than average risk, but high than average population density. And the fourth one, lower than average risk and population density. Next slide. We have then put these and mapped them and say, where are these populations in Gauteng? And you will see in red there that the areas of Tshwane in the northern part of Gauteng are the ones in the majority that have higher than average risk and population density. There are also those pockets of those in Gauteng, Ekurhuleni, but in the main is in Tshwane. And so you can follow through those color coding where the risk is. What is general as a principle is that the lower average risk in suburbs, and there is higher than average risk in townships. And we will then be able to look at this to guide how do we prioritize those communities. Next slide. So there is work that is being done now with IBM, and there is an IBM interactive viewer. This is just an electronic device that helps us to identify the maps. Where is this vulnerability? In the left upper quadrant. And then in the right upper quadrant, we are looking at information about that ward. The number, the name, the density, and so on. And then at the lower quadrants, we are giving more information. So that if you are a municipal manager, you are a district manager in Department of Health, you are a ward councillor, you can be able to have more information about that specific ward that you are overseeing. Next slide. This is an example of the 20 most vulnerable high density wards, and you will see most of them are in that northern part of Gauteng. Suffice it to say that every ward, district will be able to identify the numbers of wards, the names, the vulnerability index, and the population density in that ward. Next slide. So this work now is about what has been done in the Department of Health to try and map comorbidity as one of those risks that contribute to disease or death. And again, we have mapped them in a form of an index where we are looking at various comorbidities, particularly diabetes, TB, hypertension, and other conditions that we have mapped together to give us an index. And again, you will see with the lighter part of the colors, that's where there is a lower index, but the darker the color, the higher the index of comorbidity. So we can map where which district has the higher index for comorbidity than others. Next slide. So this is the same, but it was done for age as that category of, that's risk factor that contributes to death and mortality. We have mapped this, and you'll see in our metros in the majority That's where the index of people who are 60 and above, that's where most of those people are, and less in the peripheries. Next slide. The same is with the age group of 18 to 59. These are the groups this is the group that we are targeting for the third phase. Again, you will have more or less the same equal distribution as those in 60. And phase 3B, this is how we are now going to fine-tune phase 2B, where we are looking at those vulnerable people. Again, it is on the basis of age, comorbidities, and we have now broken them down according to those age categories and estimated their population, including phase 3, where it is going to be 18 to 59. Next slide. This slide just summarizes all the things that I have just said. We will look at the risk categories, 1, 2, 3, 4. And then on the extreme right, you will see there are numbers of wards. So we will start with the risk, the category number 1 that has 96 wards. Most at risk, there are those 235, 96, 102 in that order. And then we will also look at the other comorbidities, congregate settings, and all the vulnerability indices as was led by the GCRO. So that is really, in summary, the approach we are going to be using. It is risk-based. It is also going to be used to now communicate with our communities how we are prioritizing one community over the other, so that it is transparent and so that everybody can understand. Thank you very much.
Thank you, Dr. Okay, so I want to make the following concluding remarks. Based on the presentations that we had today, that so far the people of our province, particularly during the second wave, have done a great deal to adhere to the health protocols, what's called non-pharmaceutical measures. And that is why, in a very big way, our province did not go through the worst during the second wave. A great deal of communication and sharing of information with the residents of our province. At every stage, when the numbers were increasing, we were sending the information out to the people. And at every stage, as we were approaching the festive season, we were also sending out messages when we were picking up that people are letting the guard down. In other words, people are beginning to party. We were sending out the message there that is quite dangerous. And we're working with different sections of the population. So that helped us a great deal during the second wave. And that is why we are an exception, that the second wave, the infection rate in Gauteng during the first wave and the second wave was almost like, in absolute numbers, if you look at those two waves that Dr. Mary Kaunga presented, they're almost like at the same level. I remember very well the daily infection rate we reached, which was the highest during the first wave, was 6,500 daily infections. And during the second wave, the highest daily infection rate we reached was 6,900. There was just one day when the infection rate in one day, the number of infections were much higher. But in general, the impact of the second wave in Gauteng was not as severe as the first wave. And we want to appreciate the fact that the residents of our province took the message to heart, particularly just before we got to New Year. But it is also the truth that the level 3, the introduction of level 3 restrictions helped a great deal. And you remember level 3 restrictions were in place until we just moved back to level 1. Now, we don't think we should have level 3 restrictions. We are at level 1 now. But it will be very important that our message continues, that we should still be very cautious. The numbers talk for themselves. In the last week, this message I want to put across. In the last week, we saw an uptick in the number of infections, an uptick. It is a small uptick. In other words, the numbers going up. When we look at the week, the number of infections daily going up, even if it's just from 200 to 300, that worries us in an epidemiological week. It worries us. In 1 week, in 7 days, that would worry us. So Dr. Mary was sharing this with us. So we want to emphasize there are still 1,437 people who are in hospitals in Gauteng. 1,437 people are hospitalized. That is a big number. If you think of it, yes, having come down from 4,600 in the period of January, having come down from that, but 1,400 is still a lot of people who are hospitalized. And people are staying, the observations are that people are staying much longer in hospital. So we're sending this message again that we are not out of the woods. We still have a lot of people who are hospitalized. The number has come down, but we still have this persistence of the disease. And I've made an observation that in the 7-day average in the last week, we have seen an uptick, in other words, an increase. And where is the increase in Gauteng? The regions where the increase, we are worried about the region in the south of Gauteng, that is Sidibeng. That's where the increase is happening in the south. That's often during the first wave. That's the region that had the lowest infection rate and also mortality, the lowest. But it often comes last. In the second wave, you know that the highest infection, the region that was leading in the second wave was Tshwane. And we know what happened. It has to do with the rage event. A lot of the young people who attended the Durban rage event, when we traced all of them in Gauteng, we found that the majority of them came from Tshwane. So what drove up the infection rate in the run-up to Christmas and New Year during the festive season was the rage event. So all you need to get to the third wave is 1 or 2 events that are huge, that have a huge impact in the different parts of the province, and then the trend is established that we are now getting increases. That's why we want to send a message out there that people should still mask. Masking is still important. Don't let off the guard. Let's not lower the guard. Let's continue to mask, washing hands and sanitizing, avoiding crowds. And this is an uncomfortable message, but it must be communicated. When we see what we are seeing, it's in crowded situations where the infection, The coronavirus likes crowded places where there are a large number of people, particularly in crowded places or in closed. If you combine crowds and closed spaces, coronavirus thrives in those environments. And that's why we will be worried when large numbers of people are going to be traveling out of our province for the Easter weekend. It is at where are they gathering? At the transport nodes, the public transport nodes, and they use public transport modes which are crowded. The chances of increases in infections are high. As that happens at the public transport modes and as they travel, where will this catch up with us? Like it happened during the festive season when people come back. So after traveling in larger numbers in public transport systems, you tend to take the virus to the countryside, to the other parts of the country. And depending on what's happening in those areas, as we saw it during the festive season, the coastal provinces had a huge infection increases. Depending on what's happening in those areas, when people of our province come back from the Easter weekend, and the Easter weekend is also a period for people of faith. We've got huge religious gatherings. We are also very concerned about how this, and we're going to be working with religious leaders around this, again, to just make sure that we contain the spread of coronavirus. We are preparing for the third wave. We are preparing for the third wave. The numbers are indicating that it may be something that we don't know when, but we should be ready. The provincial government has made the following decisions. When we started with in March last year, this was done by many provinces. We brought in 4,992 COVID-related healthcare workers posts at the beginning of the outbreak of COVID. These were short-term contracts that were, and at that time, all the modeling teams, either from national or for province, were projecting that by the time we start the new year, that is 2021, the pandemic might be under control. This modeling has been revised both by our team and all the teams that COVID is going to be around for much longer than it was thought to be. So what have we done at the provincial government level? We have extended these contracts, the contracts were ending on the 31st of March 2021. We have extended this contract by another year. So these were 4,992 posts that were created, what we call them COVID-related posts, to help our healthcare system to cope. So you have doctors, you've got nurses who were brought in to help our healthcare system to cope with the pressure of the pandemic. So we have extended this by another year, so March to March. And I will explain why the trajectory that we are mapping here should take into account that we might take much longer than we thought. In addition to this COVID-related posts, the Provincial Department of Health has received a budget allocation from the provincial government to create another, this is over 1,000 posts, it's just over 1,000 posts. These additional posts are for additional infrastructure that has been created. So I said to you, we've got COVID-related special posts that were created, 4,992 posts, and we are adding into this another 1,000 posts. And these ones are deployed to infrastructure which we have created in the course of the last years. Between the March last year, when the COVID pandemic visited our shores, and March this year. So additional nurses, additional doctors, and so we have allocated a budget to the Department of Health to make sure that this new infrastructure created is going to, because it doesn't help to build and have new facilities if you do not have the staff and you do not have appropriate technologies there. Those beds will not be functional. So the Department of Health, so this preparation is happening. And part of it is just the reality, coming to terms. And I want to deal with what Dr. Mericam. We have now come to terms with the fact that it will take much longer to immunize, in this particular case, to vaccinate the number of people who will give the province and the country population immunity. And a number of reasons are clear that the vaccines, everybody is trying to get vaccines, and they will not get here as quickly as we want. So what should we be doing? On the one hand, we're saying to the people of our province, let's continue with the health protocols. Let's be cautious. Let's not let the guard down. Let's continue to ensure that these measures that have been helpful, we are cautious. But secondly, we have better capacity now. And that's why I'm talking about sustaining the number of posts we have had, extending this by a year and adding additional posts to help us manage and provide care in the additional facilities we have created. And the third intervention is continuing to vaccinate. Now, the pace of vaccination is completely not in our control. The team from health has given the briefing here. Just the over 43,000 health workers who have been vaccinated in Gauteng are a source of inspiration to us. We want to reach 215,000, but the 43,000 that have taken the jab now are a source of inspiration. It has been an honor for me to interact with some of them, to go there when they are doing the vaccinations, to talk to them and hear what they feel. It has lifted their morale. When we went through the first phase and the second phase, our healthcare workers were under tremendous stress. So we don't have the full complement of them who are vaccinated, but we have this through the implementation study that the vaccination is happening amongst the healthcare workers. It is helping us a great deal. And protecting the healthcare workers is our number one priority. But what was presented here by Dr. Senabe is important. So we are already focusing, so beyond the healthcare workers, we don't want to talk in general about the essential workers. We have now gone into detail. So once you are done with the healthcare workers, and as the vaccines arrive, and you know that we have been saying we are ready for more vaccines. As the vaccines arrive, we want to combine phase 1 and phase 2 immediately, because we are getting to winter. The level of risk amongst the elderly people, those with comorbidities, those who are much more vulnerable, the level of risk as we go into winter, the level of risk is higher. So as soon as we get more vaccines outside the study, so the first set of vaccines that are going to come, and this has been communicated nationally by the minister about when are we going to get if we get the next set of vaccines that are outside the study, in other words, from Pfizer, and those numbers, I don't want to repeat them. You people in the media have them. You know how many vaccines national government has secured from Pfizer, and those that will come from J&J. At least I remember these numbers. Pfizer was 20 million. J&J was another 9 million. J&J, you remember, is a single dose. That's outside this current study. Pfizer is double dose. So we are also planning with this in mind. You remember, managing the double dose vaccine is a complicated affair. The single dose is easier because once someone has taken their jab, all our health teams are concerned about is how are they doing? How are they doing? And that can be done by phoning them. How are they doing? Do they have any side effects or adverse events? But when it's double dose, you need to bring back. So you do the first dose, you need to bring back. So part of what Dr. Sinabe was presenting there, why are we mapping all this? We want to know where are people at greatest risk, how many of them are in this district, elderly people, some are in old age homes, but we know in our townships a lot of the elderly people are living with their families. They are not in old age. Old age homes will be easy to reach because they are establishments. So where the elderly people are, people located, the elderly people in the townships and those who are living in the suburbs, we are mapping all that. We are also mapping where are people with comorbidities. So Dr. Sinabe was presenting maps here, that you saw those maps. So our healthcare system knows how many people have what comorbidities in which area and in which ward. Because those are people who are taking medication from our health services. They constantly visit our healthcare facilities. So they are our priorities. So I'm saying to you, the day we get the larger number of doses, as the doses are coming for the different vaccines, we are very clear in Gauteng. Where are we going to start? What is our priority? Our priority is the elderly people. They are the most vulnerable in this. And then I repeat, followed together with the people with comorbidities. And then we've got other sections of our population who are more vulnerable. They live in high density areas. They live in large groups. So as we get more vaccines, we will take that into account in our vaccination program. We're not just going to be doing it at random and just going, so the infrastructure that we have put in place, the Department of Health infrastructure, the number of vaccinators trained, the health facilities identified, they are now being mapped together with the vulnerability risk that was presented earlier on here. So the task of a province, we're not procuring vaccines, we receive vaccines. As we receive the vaccines, we have now worked out what will be our area of priority. As I say, we're concerned about winter, but we are also concerned about what will come out of the Easter weekend, where there's going to be high movement of people and mobility throughout, intense mobility throughout the province. So the third wave is like we did with the second wave. The third wave may happen at some point or the other, but it's not given what the impact would be. It depends on what we do. It depends on what we do. The second wave was not as severe as in terms of infections, including in terms of the number of the hospitalization, the highest number of people in hospital. Of course, it is more severe in terms of how long people are staying in hospital in that way. And we don't know. The third wave may be more severe. And it's a function, as Dr. Mary Kaunga said, it's a function of what happens with these viruses. If there's a new variant and we are not in control there, the third wave. So there are things we can do, and there are things we are doing as the provincial government. And one of those is to truly be absolutely clear about where the vaccines are going to go first. And these are based on science. This identification is based on science and strong values. You protect the most vulnerable first. We can't take the vaccines and take them to the young people who are less at risk. We must take the vaccines to those who are more vulnerable first, who are most vulnerable first and at greatest risk. And the rest of us will just stay on the queue. Maybe a little bit longer. But phase 1 and 2, we're not going to separate phase 1 and 2 for long. Yes, we want to complete the healthcare workers, but we immediately want to move as we're now getting into winter. We want to also move into the areas of greatest risk so that we also have not stopped our normal flu immunization program. The last winter in 2020, we escalated and increased our flu immunization protection. Protection is important to protect ourselves from all kinds of infections. I know that many of us last winter, we didn't get the flu, many of us, because what works also, the doctors are explaining it this way, that wearing the masks and sanitizing also helps us to protect us from just general infections that happen on an annual basis. And that is why I want to really conclude by continuing to appeal to the people of our province. This is not time to say throw away the mask. This is not time to say we're going to go into gatherings. The infection rate has gone down. If you look at where we were at the peak of the second wave, but we are worried. We are worried of the persistence of the infections have not stopped. We are worried by the persistence of that. We are also worried that there are still a lot of people who are hospitalized, and we are still losing a lot of people who are succumbing to COVID-19. Tabo, we can take questions now.
Okay, thank you, Premier. Do we have hands here? Yes. Where's the mic?
Thank you. It's Gauteng here from ENCA. Premier, I'd just like to know, at this point, considering the pace of your vaccination rollout program, the vaccination rollout, and the comments by the Advisory Council that the equilibrium is delicate at this point, and that the restrictions are still in place, is it possible to avoid a third wave? And then I just wanted to check, considering that you've only vaccinated 43,000 healthcare workers out of 215,000 in the province, at which point will you start the rollout of phase 2 among the people that you've just described? What I'm asking is, will the J&J clinical study entail or encompass all 175,000 healthcare workers in the province, or will you be using the Pfizer vaccine to finish the healthcare workers before you start vaccinating other population groups? If not, do you have a date when you will begin vaccinating under the phase 2 groups? And then, Premier, you've mentioned the Easter restrictions, the Easter traveling. Will the Gauteng Provincial Command Council be calling for any restrictions to be placed on traveling in the province over the Easter period? And so, that's it, thank you.
Okay, thank you. Do I see any hand here? Any more? Okay, going. I don't see any questions on the WhatsApp. Okay, so we will then go ahead and answer those ones. I don't know if Dr. Mukherjee wants to say something. There was a question about the vaccination program, or you think the Premier will be able to deal with all of them? Or Mrs. Mope?
I think the Premier did mention it, just to reiterate what the Premier said.
Okay, if you want, you may come. Let me see.
I want maybe to deal with, is it possible
Yes.
to avoid the third?
Okay, let's have Dr. Kaonga to speak about the question of the third wave.
Is it possible to avoid?
Please come forward.
Thanks for that difficult question. I don't think it's, we're sort of saying we'll stop the wave. What we are saying is, I think it's possible to push it back and make it flatter by the actions that we take. So I think what we've seen from previous waves, not just in South Africa but elsewhere, often in most situations, if there's adherence to non-pharmaceutical interventions and people are actually taking the protocols for safety and protection, perhaps it can make a difference in terms of keeping the numbers as low as possible to avoid that resurgence that then puts a strain on our hospitals. And that's really what we're really looking for. It's not to say we stop it completely. I think COVID-19 still has business with the people. And until we get to a point where we have sufficient community herd immunity or population immunity, one can't really say that we can actually stop it. But we can reduce its impact by pushing it maybe further away and flattening it a little bit more so that the peaks we get are not as high as we saw previously. Thank you. Is it a follow-up question?
All right.
Just to clarify the question, sorry. Then just on that point, I think I was asking more in relation to the relationship between the waves and the vaccination drives.
Right.
So whether or not it's possible for us to push back the wave until the vaccination drive is at a level where it can stop it. And then if I can ask it more directly then, is the pace of the vaccination drive making the third wave inevitable, which I think you've answered? And what I want to know is, considering the pace of the vaccination drive, do you believe that after the third wave that will be it? Or are we vaccinating so slowly that we might risk it?
I wish I was a soothsayer or a fortune teller. Look, the thing about every time there's a wave, more people get infected, and the expectation is then there's more natural immunity from people having had the infection. So maybe I think a lot of the scientists across the world are saying that subsequent waves that come are expected to be smaller than previous ones, partly because of natural immunity, and partly because of, as vaccination programs take off, we now start putting in also the vaccination-based immunity. The thing that's still hanging is about the impact of different variants and whether we'll see more variants coming up, and that's unpredictable. One can't really factor that into that equation. So I think a lot of the thinking currently is based on what we understand, based on epidemiological patterns that we've seen in this SARS-CoV-2 pandemic, as well as previous pandemics in terms of how they work. So yeah, I hope that answers your question. Thanks.
Yeah, okay.
I think one of the things that we are also seeing in other parts of the world is that even though the vaccination is happening, there are countries that are vaccinated much higher or larger numbers of people, but there is the third wave happening. So it is important to look at that, the question at which point the vaccination may, and I'm talking about countries in Europe which are now going for what we wouldn't want to go back to, to lock down and close down schools. And they are doing that in the midst of a vaccination program that has reached a larger number. So I would say that I think it's important that we undertake a combination of measures. Yes, our faith, and I want to use that word faith, our faith is in the vaccines. But you would know that as the new variants emerge in different parts of the world, they also challenge the vaccines that are around. And that's why we talk about vaccines and not vaccine, so that we are more open-minded, and it's an ongoing experiment, which vaccine and which vaccines, as they are being used in different parts of the world and also being tested also against new variants that are emerging, which vaccines are much more effective. So I'll use that the backdrop of that question to answer your other question about at which point will phase 2 start. So what we have now is what is called a phase 3B early access, and it's called implementation study. You remember when we wanted to start with AstraZeneca, we were going to start with phase 1. So what was presented here, we're going to use AstraZeneca for our healthcare workers and do 215,000 of them in Gauteng. And all over the country is over 1 million healthcare workers. That original plan, the vaccine may change, but the original plan that we start with the healthcare workers and we must complete the healthcare workers based on how soon we will get how many vaccines. So that doesn't change. So phase 1, which is currently linked, it would currently be linked with 3B, the implementation study, but we're hoping for the larger number of doses that will be delivered. The next larger number of doses that, and I don't want to speculate. If we get, say we get 600,000 vaccine doses, we will be able to do the healthcare workers, the remainder of the healthcare workers, and start doing what the presentation says we will do. Who amongst those at risk are at greatest risk? Again, it will be based on the number of doses that we are receiving. The whole world is doing the same when they receive their doses. So the separation between phase 1 and 2 will be narrowed. At least we know that the last group of people in phase 3 is when we are satisfied that we have covered people at great risk and those who are most vulnerable. and you understand. When you say, can I say, put a date? I can't put a date. I can only put it like this: as soon as we get the vaccines, our machinery is ready, and we know. Firstly, complete the healthcare workers. And secondly, go as quickly as possible. As I say, because we are getting into winter and the possibility of a third wave is very, very high. Go as quickly as possible to reach. So we have mapped them and we know where they are, the people at great risk. And if we get the number of vaccines, I gave you this abstract number. Whatever number of vaccines we will get, we will make sure we roll them out as swiftly as possible to cover and it doesn't matter whether it's J&J or it's Pfizer. The only complication with Pfizer is that you do the first dose and then there must be a separation of time. After how long? It's 4 weeks for the second dose. And that, I want to say that our immunization experience tells us that 2-dose vaccines are often a big challenge. And we want to do it in a way that we can trace where people are. That the localization is truly, truly local. So we know you have taken the first dose. So we have many immunization programs where people don't do the follow-up and they undermine the effectiveness of our vaccines. So the team from health was briefing me that some of our vaccination programs, our immunization programs are suffering from the mobility of people in Gauteng. Someone was in the West Rand, they've now moved to the East Rand. They've changed address or they have moved to another province. They were working here, they no longer work here, they've moved to the home province. But all that are the things we are managing so the key thing for us is it is critical. We need the vaccination program to move to the next level. And we understand, we get briefed by the national minister and also at the Presidential Coordinating Council. We understand, but you can understand that I can't wait. Thinking of post-Easter, I am telling you, we are going to have a lot more people who may be infected as a result of the effect of travel. You asking a question, will you propose or introduce restrictions? I wouldn't want us to entertain that. Last Easter, it was very difficult to say people must not travel. I tried it last Easter. It didn't work. I said people shouldn't go. And at that time, last Easter was in the middle of a level 5 lockdown. But it was Easter. People traveled. It was part of the impact of COVID-19. It's just the stress. We are human. The stress, the impact of it on people, and some of the needs to move to go to another province, maybe a function of that. If we do all other things, and we should do all other things, it shouldn't be necessary to impose restrictions. And I want to say that we can have people cooperating and taking measures to ensure that the spread of coronavirus is contained, as they did during the second wave, especially between January and February, mid-February in Gauteng province. I have never seen people who were so conscientious. Yes, there were level 3 regulations that said put on a mask. We did roadblocks. We checked. We went everywhere, did roadblocks. We checked. People were wearing. They were putting an effort in understanding that they need to protect themselves and protect those that they interact with. So I wouldn't entertain the idea of travel restrictions. I think it's unrealistic. It wouldn't work because how do you stop people from moving? But also I would think that we want the economy to be open because when the economy is open, it helps more people to earn income. It helps to have a development impact. So we would like, the reason we must combine all these measures, the reason we must not let the guard down is that it helps us to keep the infection rate lower. It helps us not to have level 3 restrictions. It helps us not to go back to level 3 or level 4. But that depends quite a lot on what happens. The behavior of the pandemic depends on the behavior of people. If suddenly we reach a point where the numbers just shoot the roof, the infection rate shoots the roof, I think government is going to be forced to do what governments are doing right now, even when they are vaccinating. Government. There are governments that are vaccinating, but they are shutting down. I think that's the option that must really be like an unavoidable, and we can avoid that by doing a number of things here. That so as we get the vaccines, we will roll out those vaccines as swiftly as we can. And in fact, this morning I was saying to the team from health, if we were to get a large batch of vaccines very quickly, as is the plan of the Republic, if we were to get that last batch, our machinery on the ground should be such that we will be able to vaccinate on a daily basis the large number of people. And we are following what others are doing in different parts of the world. Even in our continent, we're looking at what Rwanda is doing, how many people they are able to vaccinate in one day. We are looking at what's happening elsewhere in Asia, in Europe, in the Americas, and drawing important lessons there. So the critical thing for us is just getting the vaccines. So we can answer your question when the vaccines arrive. When the vaccines arrive, in this province, we've just proven with the early study. And this is both the public and the private sector. We've been collaborating extremely well. I just wish it would stay like this. We've been working very closely, the private health and the public health sector in our province, working very closely. We will do the same with phase 2 and phase 3. We will do the same as well. There are a lot of people that the private sector can take care of, people who are on medical aids. Our task is to principally look at the vulnerable sections who depend entirely on government, and they were mapped in Dr. Snave's presentation. The middle classes, that's why we want to work with the private sector to make sure that those who do principally use a lot of private healthcare services, the private health facilities will also be ready. We want to cooperate with the pharmacies. We want to cooperate with a whole host of institutions so that when we have a sufficient number of vaccines, and I'm confident we will reach the point where we will get, I know that the Minister of Health is working extremely hard. Our President is working extremely hard to make sure that South Africa gets as many vaccines as vaccines are going elsewhere in the world. So I have confidence in them. I have confidence in President Ramaphosa. I have confidence in Minister Dr. Zweli Mkhize they understand that this is an emergency and vaccines save life. So from where we are on the front line, we receive vaccines and we want to make sure they get to the relevant people. There's also been reports that are being followed up where there may be people who have maneuvered their way into the vaccination program. At least the management of this is being done by the Medical Research Council. They have been following up on some of those allegations that have arisen about people who don't qualify, who get onto the program. But we will do everything to make sure that the people, only those who are categorized facing greatest risk, and they are frontline healthcare workers, are going to receive priority. Thank you very much. I hope I have answered your question. No restrictions for Easter. All I can say to you is that it will not work. But we want to appeal to people's cooperation because they traveled in December. As I say, we saw them on the roads. They put a great deal of effort to make sure that even though they travel, they take measures to protect themselves and protect those close to them. Thank you, Thabo. I think we are done.
Yeah. Thank you very much. Sure. Yes, yeah. Yeah, we can easily say that. Yes.